Hello everyone. Welcome to this series of continuing education videos that I'll be posting. Amongst the first videos that I want to make is a topic which is very close to my heart, something which is clinically very relevant, and that is about immediate placements. And I want to highlight the 6 rules that anyone who is doing immediate placements should follow. So let's begin. The first rule is that the buccal bone should be intact if you're considering a placement of an implant immediately in an extraction socket. If there is no buccal bone, it's better not to plan an immediate placement. In that case, it's prudent to extract, wait for a period of 8 to 10 weeks for the epithelium and the soft tissue to heal, and then go ahead with the early placement protocol. But if you are an advanced, experienced implant user, then in certain cases in the buccal bone absence, still techniques can be done to place an implant immediately and regenerate the entire buccal bone. But I will refrain from talking about those techniques today. And so we'll consider that this is for a beginner, this lecture, so that when you are a beginner, when the buccal bone is absent, you do not do an immediate placement. The main reason is if you look at this slide over here, the topography of the bone in this region is such that there is always a presence of dehiscence or a fenestration. And when the buccal bone is absent, you place the implant in the socket, the wound as it heals will not form buccal bone over there, and placement of an implant in this socket can lead to mucosal recession and then a longer crown and an anesthetic end result. Plus the gray color of the implant can show through. There is no predictable way to generate this buccal bone, and so at a beginner level it's better to refrain from placing an implant in a socket in which the buccal bone or the labial bone is absent. If you have a scan section like this, as you can see in these red rectangles on the slide, and there is absence of buccal bone either partially or fully, it's better to extract and wait and not place the implant at the same day, because it can lead to an unpredictable outcome. And our goal of this lecture is to follow these 6 rules so that we have a predictable outcome when healing after an immediate placement, and the success rate is as good or as high as a conventional placement would be in a healed site. So as you can see in this green rectangle, when I'm looking at the offending tooth which needs to be removed and an implant planned in the socket, I need to see a few things in that, and the number one thing that I will watch is whether there is presence of buccal bone or not. And so if the buccal bone is present, this socket is conducive to immediate placement, and following the principles that we'll now be discussing, an immediate placement can be done. So from this, it's needless to emphasize that for an immediate placement, a CBCT is always mandatory. If you don't have a CBCT, you will not be able to judge whether the buccal bone is absent or present, and then your protocol can go completely wrong and lead to a loss of an implant or loss of aesthetics for an implant in the aesthetic zone. Okay, so rule number 1, no buccal bone, no immediate placement in a socket. The second rule is that the implant should always be placed in a prosthetically correct 3D position. So when you look at the 3D position of an implant, let's look at the 3 dimensions. The first dimension is the placement of the implant depth, and the depth of the implant as per literature should be around 3 millimeters from the free gingival margin of the teeth that you're going to be replacing, or 2 millimeters apical to the CEJ. But these are old numbers. In modern day implantology, we want the placement of the implant to be at least 3 millimeters to 4 millimeters from the CEJ of the adjacent tooth, and that would get it around 5 millimeters or so from the free gingival margin. This depth is important so that we get a proper emergence profile of the final restoration from the socket. And this is not only valid for the anterior teeth, this depth is even valid for the posterior teeth. So the depth of the implant placement should be 3 millimeters deeper than the CEJ of the adjacent teeth, which you will judge on a radiograph after your drilling protocol has been initiated. Mesiodistally, the implant should be placed in the safe zone, as you can see in this picture here with the green zone, which is a safe zone, keeping a distance of at least 2 millimeters from the adjacent teeth, and this distance could be a little more for posterior teeth, but your implant should be in the center of the final tooth that you're going to be replacing. When you look at the position of the implant accordingly, in fact, I mentioned that you have to place your implant in the anterior socket in such a way that the implant's axis emerges from the lingual face of the final tooth and not from the lingual side, not from the center. The lingual location is to the lingual fossa of the final tooth, and that gives you a proper buccolingual placement of the implant so that it allows you to make a true retained restoration comfortably in the aesthetic zone. When you're looking at the premolars and molars, the screw access must come from the center of the central fossa of the posterior teeth. So the implant should be in a prosthetically correct 3D position, and that's a rule of immediate placement, because in a heel side, that is something which we always desire. So in an immediate placement, we don't want to end up placing the implant in a multi-rooted tooth, especially in a mesial or a distal socket. And the implant for posterior zone should be then placed in the furcation area of the roots that we are replacing. The third rule is that you need a high insertion torque, and that is mandatory. It's a non-negotiable point. If you do not get stability of upwards of 30 to 35 Newton centimeter within your implant socket after placement of your implant, you will need to abort the placement, or then you will need to try and achieve a primary closure for that area to protect the implant, which is a very difficult thing to do. It will get us more elaborated on this point in the next rule. But the third rule, that high insertion torque is mandatory, is important because if you're not an experienced user, then you might not be able to judge the density of the bone and the positioning of the implant to get the required stability that you want in the socket. So make it a point to see to it that you get high insertion torque, and for that your implant design should be chosen in such a way that even if the 2 or 3 threads of the implant engage the apical or the middle part of the osteotomy, you should be able to get a high torque value. And that's important for your post-implant insertion prosthetic protocol. The fourth rule is don't raise the conventional flap. Don't raise the marginal gingiva around the area where you are placing an implant. Your implant placement should look like this in the posterior sockets in the upper or the lower molar, or in the anterior socket, as you can see over here. You don't want your implant flap to be raised around this side. If you do that, you are going to compromise the blood supply of the buccal bone in a very big manner, and compromisation of the blood supply will lead to more bone loss, and the labial bone, which is anyway very thin in certain areas of the jaw, will be more prone to resorption, and when the labial bone resorbs, the mucosa can undergo recession along with it, leading to an anesthetic outcome. So if you need to raise a flap due to any reason in around an immediate implant placement, that flap should be of a special design. As you can see here, it's a remote incision, a semilunar incision in the movable part of the mucosa to gain access to the apical pathology, be it a granuloma or a cyst or whatever periapical lesion is there. That can be done so that you can curate the entire area out, and then if desirable, you can add a bone grafting material over there. So no conventional flaps to prevent labial bone loss. The next question or the rule is whether gaps around the implant should be grafted or not. So the rule is that if you have a gap of more than 2 millimeters between the body of the implant and the socket wall, or if your labial bone was less than 1 millimeter in your preoperative assessment, then in that case grafting is mandatory. It should be done in this gap. Especially in the anterior socket, the labial bone is always thin. So even if the gap is not much, because the labial bone is thin, it's prudent to add some bone graft between the implant body and the surrounding socket wall to prevent future loss of the labial bone. Remember that whatever grafting has to be done can be done only on the day of implant placement, and it cannot be done later on. So this is your best chance to enhance biology. So in these sockets, when the gap is more than 2 mm or the labial bone is less than 1 mm, we always consider grafting. Question always arises as to which bone grafting material to use. Our most favorite material to use, or most desirable, is to use autogenous bone itself. And With the modern drilling protocols, when we are drilling the osteotomy sites at a lower speed of 300 to 400 RPM, we collect a lot of bone shavings, and these can be added back into the sockets. If you don't have enough of this autogenous bone, you could use an allograft or a xenograft in that site. But these xenografts have to be such that they will get resorbed and replaced by body's own particle and act as a scaffold. We do not want the xenograft to stay there as xenograft in the socket for a very long period of time, because that will in effect affect the osseointegration quality and the bone to implant contact in the long term. So autogenous is number one, allograft is number two, and a xenograft which will allow the body to replace it with its own bone is the desirable grafting material to use. We don't recommend use of synthetic bone grafts in this type of a clinical scenario. The last rule is don't try to achieve primary closure. When you place an implant in a socket, as you can see here, now you don't want to raise the entire flap because that will violate your rule number 4, which we talked earlier, and you don't want to uh, move the entire mucogingival junction to try and achieve a primary closure over here, because that act itself will lead to a lot of bone loss and contour. So we don't want to do that. And so what we would desire to do in a posterior socket is make a custom healing abutment like this chair side, which can then be fitted onto the implant at the same time. And making of a custom healing abutment like this will allow us to seal the socket prosthetically from the coronal aspect. So now you will have the implant with high stability in the center with a flapless placement protocol. You will have a gap which is, if large, grafted with the grafting material, and from top you have the custom milling abutment sealing the socket, which will then allow you to create a 5-wall defect within the implant, within the socket itself. And because the socket is programmed to form bone, whatever blood clot forms in this zone will now become bone itself, and you will have very good bone levels around these implants. In the aesthetic zone, we don't want to place a custom healing abutment because anyway a provisional restoration is required. So in the aesthetic zone, we make an immediate chair side provisional restoration, which is always screw retained and kept out of occlusion completely in centric as well as eccentric positions, so that this will allow us to seal the socket and achieve the same result as we would have achieved with our protocol of the custom healing abutment in the posterior. So when we make provisional restoration in the anterior and custom healing abutments in the posterior, we will be able to provide the primary closure that we want prosthetically, and thereby the need for us to raise a flap and achieve primary closure will be completely eliminated. Here I present a bouquet of some of my cases where a single implant is done in the aesthetic zone with this immediate placement protocol following all these 6 rules. That's 2 adjacent implants maintaining the contour of the root and the soft tissue around the implant following the rules that we discussed. This is a 3-unit bridge with 2 implants and 1 pontic. So the central incisor, tooth number 1, is a pontic, and look at the beautiful contours that have been achieved around these sites with the immediate placement protocols and the rules that we followed. And that's the side view of the same case, showing you the excellent outcome of the soft tissue. It's not only the quantity but even the quality of soft tissue. In this case, of course, we have done PET, which I'll discuss in detail in some other video, but the protocol of placement has been an immediate one. And here we have been able to harness the full biologic potential of the healing socket to get the emergence that we wanted. And this is a more complicated case. 4 incisors missing, so 2 implants, both of them in the central incisor region, and both lateral incisors are a pontic. And you can see how beautiful the contours are following all the rules that we discussed so far. That's an immediate molar, which allows us to place the implant in a perfect position, getting all the papilla intact so that we don't have food lodgement areas around there. And that's immediate molar placement in the upper jaw, where 2 adjacent implants were placed at different times with the immediate protocol following the rules that we discussed. And so when we follow these protocols well and make a custom healing abutment, when we remove the custom healing abutment at a period of 3 or 4 months, we get this beautiful topography of the soft tissue of the implant supracranial complex, which can then be copied into the final restoration, thereby allowing a pristine emergence profile for all these immediate placements that we routinely do for our patients. And a similar site here in the aesthetic zone for the canine, where this was achieved, the immediate placement protocol, where we could achieve the contouring and the festooning of the root maintained beautifully by the protocol that we followed. So immediate protocols here were usually done without any graft or biomaterials because the label bone was thick enough and the gap was not that big. So we were able to achieve these results with just a perfect placement of the implant in the socket, the 3D placement, a flapless placement, making a provisional restoration, and then copying that contour to copy the emergence in the final restoration in one surgical appointment. The price, of course, is a full arch case in which all the immediate placement protocols like this can be applied to every socket, and then the contours can be maintained for central, lateral, canine, premolars, and beautifully the protocols can be done with immediate placement following these 6 rules. And so here is a bouquet of all the cases which we have seen, some of them in this presentation, and done routinely chair side protocols for immediate placement following all the 6 rules. And that's one case in which I have to place an immediate placement in the second molar region and a delayed placement in the first molar. And when I look at the side, there is not sufficient bone everywhere to place the implant. So I make a purchase point for the 4-6 region and then do the extraction for the 4-7. But when I raise a flap, I follow the rule of not having a flap raised for the immediate placement. For 4-7, no flap has been raised, thereby maintaining the entire circulation of the periosteum intact in that area for the labial bone to maintain the topography. And then the osteotomy is completed. The 2 implants are placed as desired in their perfectly prosthetically driven positions, and the 4-7 is flapless. Then 2 custom milling abutments are fabricated, and whatever autogenous bone was collected was put back in the socket, and the custom milling abutments were torqued to a value of around 10 to 15 Newton centimeters on the implants, which are themselves at the torque value of 35 to 40 Newton centimeters, and then just a holding suture to hold the flap in the 4-6 region. After 4 months, when we remove the site, we have got beautiful integration of the implant, great bone levels around the implant, and we have got the entire implant supracrystal complex managed and maintained beautifully because of the custom milling abutment placed. So we make 2 screw-retained crowns, and that's our final restoration. So friends, to reiterate all the 6 rules, we have to see to it that all of them are followed in our cases. And when you do that consistently, you will be able to harness the full biologic potential of the healing socket and place the implants with a very high degree of predictability with good emergence in these areas. So here, I hope this presentation was of use to you, and these tips will be of far great value to you in your practice. Thank you very much.